All right, welcome back everybody, and really been looking forward to this session for a couple of reasons. One, when we talk to our families with CHARGE, probably one of the most overwhelmingly frequent problems and issues that come up is GI related, and it can range from chronic constipation to belly pain, abdominal migraine, trouble feeding, trouble with G tubes, GJ tubes. It's just so protean and such a consistent part of CHARGE syndrome that we really wanted to try and get some good information out there and the latest what we understand about it. Second reason I'm really excited is because the panel that we've got together is fantastic. So first off will be Ajay Kaul from Gastroenterology. He'll talk about some feeding disorder related issues in CHARGE. Next will be Jason Fisher, who runs our colorectal surgical program. It's really key that thankfully we got Amy Russo to join us from a parent perspective, and she's lived through a lot of this and will probably resonate with a lot of you guys out there. And then batting cleanup for it is Kim Blake, who's up in Canada and joining us virtually remotely from her place. And as you know, if you're part of the CHARGE community, Kim has been working on this both in a basic science a research approach to this, but also in her clinical practice and dealing with all aspects of CHARGE. So let's kick it off. We'll have Ajay start. Thank you so much for joining us. Ajay, you can lose the mask. We're in a socially distanced and safe place. Ooh, everybody wants to see you talk. So thanks again for joining us.
Thanks, Dan, and welcome to this session. We're going to start off with me, Ajay Kaul. We'll be talking about feeding issues in CHARGE syndrome, and then we'll be followed by my colleague, Jason Fisher, who'll be talking about the other end. Constipation, etc. So I just have about 15 minutes to talk about this feeding issues in children in CHARGE. So really, feeding issues are universal. Literally 100% of children that have CHARGE syndrome will have a feeding issue. The issues are primarily more acute in the younger age group. It tends to get better with time. And obviously, that's if they get the optimal treatment at the right time. We'll talk a little bit more about that. So the first question is, why do our children with CHARGE syndrome have these feeding difficulties? So if you categorize those causes, you can really just divide them into three major categories. They could be either from structural defects, they could be from sensory issues, or they could be from motor function. Motor function means when there's lack of good contractions in the intestines or the esophagus, etc. The sensation and motor function, as you see on the slide, is affected due to involvement of several cranial nerves, the 5th, the 7th, 8th, 9th, 10th, and the 11th cranial nerves. So you can see more than half the cranial nerves are involved in children with CHARGE syndrome. There's not a lot of data in humans about the involvement of the enteric nervous system in CHARGE syndrome, although there are some experiments in animals that have shown that there's some abnormalities in their enteric nervous system. So what is the enteric nervous system? The enteric nervous system is a whole set of nervous system that's embedded within the wall of the gut. And it can oftentimes work independently of the central nervous system. The enteric nervous system has also been sometimes referred to as the little brain, and it's all embedded within the gut. So if that's affected, then you have problems with both sensation and motor activity of the gut. So you don't sense things well, you don't push things down the GI tract appropriately, and therefore those things can cause problems. So this is a cartoon of the head and neck, and in this picture you can see the various causes as to what that can give rise to feeding disorders in our children with CHARGE. So if you look from the top, the first thing, coloboma, the vision is affected, the sense of smell is affected because of the olfactory nerve involvement. They have choanal atresia, some of them have cleft palates, then they have taste involvement, they have lack of taste, development of taste buds, involvement of the facial nerve and the glossopharyngeal nerves, again, both cranial nerves. They oftentimes have a relatively large tongue that fills up their mouth cavity. Then they can have poor mastication muscles, so they can't really chew well. They have enlarged adenoids and tonsils sometimes that cause more crowding of the oropharynx and impact the normal swallowing. Then the pharynx, which is the back of the throat, sometimes is weak and the muscles there don't squeeze hard enough when you swallow for the bolus to be pushed down into the esophagus. So there's the list that I've kind of written on the right of your screen. You have visual impairment, which is a structural abnormality. You have choanal atresia, narrowing, that's again a structural abnormality. Abnormal sense of smell, abnormal chewing, cleft palate, relative macroglossia, which is a relatively large tongue, abnormal taste sensation, weak pharyngeal contraction. And in addition to all of these structural and sensory and motor abnormalities, you also have developmental delays and behavioral disorders that will impact their feeding abilities. So when you move down, we just looked at the head and the neck, but if you move down the GI tract, you can see that after the pharynx comes the esophagus and then into the stomach. And the esophagus and the stomach can also be impacted by structural, sensory, and motor abnormalities, and some of these are listed on the right. So you can have an abnormal relaxation of the upper esophageal sphincter. So that sphincter muscle that's at the top of the esophagus doesn't relax well, so it doesn't allow the food to actually easily pass into the esophagus. Then you can have a laryngeal cleft. So that's a midline cleft communication between the esophagus and the airway where you can start aspirating, and that can lead to huge feeding disorders. Then you can be born with a tracheoesophageal fistula, again, an abnormal connection between the trachea and the esophagus that needs surgical correction. Some of the children have vascular rings, which are, again, structural abnormalities of the major blood vessels around the esophagus, and they impact and impinge on the esophagus such that when the bolus is swallowed as it's going down the esophagus, that impingement acts as a barrier to the movement of the food down the esophagus. In addition, if you have cardiorespiratory conditions that impact your ability, your strength, causes you to have fatigue, muscle fatigue, and you can't really swallow well. Then you can have esophageal motility problems. Normally, when you swallow something, it goes into your esophagus, provided it gets there appropriately. Then the esophagus starts to contract and push that food down the esophagus into the stomach. If you don't really have those normal contractions, and a lot of our children don't, then that food tends to stick in the esophagus and not move down the esophagus, causing the child to gag and retch and cough. Then again, just like the upper esophageal sphincter abnormality, you could have problems with the functioning of the lower esophageal sphincter, which is the valve between the esophagus and the stomach, such that it's really loose and it predisposes our children to having more reflux and pretty severe reflux. And on top of that, when all that acidic stuff comes up into the esophagus, you have poor esophageal motility or contractions, and you cannot clear that acid from the esophagus, which tends to sit on the esophagus and cause some burning, and gastroesophageal reflux disease ensues. And then the last one listed there is gastroparesis, which is a condition where the stomach doesn't really contract well, and it's slow to empty as a result primarily of, we think, vagal nerve involvement, because vagus nerve is very important in the motility of the stomach. And if that's affected, then you don't really have good contraction in the stomach to empty your stomach, and food just sits in the stomach and you feel easily full. There's early satiety. You don't eat after the first few bites because if you eat more, the stomach gets overfilled and you start to retch and gag. So there's those examples of several examples I've listed as to why our kids with CHARGE syndrome have these feeding difficulties. That's really all I have for now, but I just wanted to touch a little bit. I know I just have 10 minutes, but a few things about management. So really, it's been impressed upon all of us over the course of the day today that an interdisciplinary approach is critical for the best outcomes of our children with CHARGE syndrome. And what that means is you have a host of experts in all of those necessary fields, disciplines, including ENT and the surgical branches, the gastroenterologist, the ophthalmologist, etc., on the team, and we see these patients either together or at least we communicate with each other after we've seen the child and are discuss them periodically in our regular periodic meetings. So at our center, you've heard about our area digestive center and the interdisciplinary feeding team, and most of our children with CHARGE syndrome are seen in these two clinics. And I've had the honor of being part of both of these teams for about 10 years, back 22 decades ago. Let's not go there. So really now coming to research, there's a huge gap in the knowledge of what's happening in CHARGE syndrome as far as the gut is concerned. There's really not a whole lot of bench or translational or clinical research that's out there. If you do a search, a PubMed search on this, there's really not a whole lot that's been published. And it's really exciting to see some of our researchers, including Dr. Kim Blake, that you're going to be hearing from later on, about all those exciting studies in animals that are kind of helping us understand some of the issues that are going on in children with CHARGE syndrome. So that includes bench research and then translational research, and then of course clinical research. And one of the things, and I'll end with that, is that the CHARGE community can really help us with a lot of the clinical research in terms of things like quality of life. And these are just questionnaire-based research that y'all can help us with. Filling up the questionnaire, and these are standardized, validated questionnaires that we can fill and get some preliminary data on to really understand what's going on with these children as they grow up at different stages in their careers, and then kind of grow from there. So, and then I'll just put this plug in at the end that GI, even though GI issues are not really considered a top priority in the list of conditions that these children are going through that are more life-threatening, including cardiac and respiratory, but they really need to be involved from the very beginning, because some of the issues like feeding disorders need to be addressed early on as the rest of the other conditions are being taken care of, so that we don't lose that window of development of things like oral motor skills, etc. And it becomes harder to treat those when they are much more stable as they get older. And that's all I have. Thank you.
Thanks, Ajay. So let me ask you one question.
Mm-hmm.
From the GI perspective. From the ENT side, we've put a protocol in place now where at some point every kid who has a CHARGE diagnosis, we recommend coming through for an endoscopy, because in more than 52% of our kids, we found that they had an occult something, maybe a laryngeal cleft, something subtle, or significant laryngomalacia is probably the most obvious thing. From the GI side, what would you think, are there any standard tests that you would recommend that, like, should they all have an impedance probe or an upper endoscopy, or is there anything, a modified video swallow study? What kind of things do you think would be reasonable?
So that's a great question, Dan, and thank you. So the critical thing here is interdisciplinary care. And if a child is going under anesthesia for any reason, and there are several times they will go under anesthesia, most of these kids have multiple surgeries, I would strongly recommend as a gastroenterologist that you include us in at least one of those early instances where we can go down the esophagus and actually look at the stomach. They start to look for any congenital structural disorders that we talked about, or even, identify some functional issues that could be addressed at the same time. It really just takes about 5 minutes to add an endoscopy to those procedures. So that for sure, and try to get as much bang for your buck under one anesthesia and get that done. So that would be my one thing that I would definitely recommend. There's not, if you look at there's really no consensus which includes GI as a major player in the care of children with CHARGE syndrome. And I really want to put a plug in that we really need to be involved with these children from the get-go. The other things is it depends on the child's primary symptoms. If a child's having a feeding issue, as we all know, 100% of these kids will have a feeding issue. So I would strongly recommend doing a video fluoroscopic swallow study to make sure that there's no hidden aspiration or silent aspiration, and pick those up early on, because if you don't, then you have the long-term complications of lung problems, chronic scarring of the lungs, which can impact their lifestyle and their quality of life later on. So we definitely would need to do a video swallow study upfront. And I'd really like to see a gastroenterologist involved in a consensus where we all come up with a consensus to, develop these centers of excellence like we have in Cincinnati and in other places, and kind of come up with a consensus of how we should standardize their care and try to group all of this care together and not do this fragmented care, which unfortunately a lot of our kids have to undergo at different centers.
Hey, Kim, before we jump to Jason, so you've developed a checklist that kind of makes sure that we methodically go through all the issues with CHARGE. Is there anything on your checklist I couldn't remember off the top of my head that relates to this aspect? Like, should we be doing swallow studies or anything like that as a baseline?
I think actually you've taken up my second and third slide. I've got the checklist there actually, so we can have a look at it together. But
okay, good.
There's certainly a lovely section on GI. It's as you've all said, and I think everybody said across your conference, is that it's missed. It's missed. I think the most important thing for our first speaker is get them in the door. Make sure they're getting to be assessed. And I think that really would cover a lot of all evils, because it gets missed. It gets forgotten, because you've got all the airway problems, you've got all the heart problems, you've got everything else. So I would actually very much agree. Just get them to see a gastroenterologist, number one, and a feeding team, number two, and then go from there.
All right. Jason, why don't you take it from here? Yeah, we'll pass off the advance. The big button.
Middle one.
Excellent. Well, Dan, thank you for inviting me and bringing me to this conference and having me involved in some of the CHARGE patients. I know I remember talking about this with you about probably a year and a half ago now, and Lucy, and just trying to figure out, and a common theme I'm hearing is multidisciplinary approach and quality of life. And so I think some of the slides I'll touch upon that. And as you participate in a big center like we have the luxury of having people who could do that. And so I get to take care of the back end of things. And so you have no idea what I talk about at my dinner table with my children, but feel free to ask any questions you want, because it's all fair game. The first thing I'd like to mention, this is a picture from the cover of New York Magazine about 15 or 20 years ago. And it's a child who had open heart surgery. And this is probably before the time of FaceTime, and Instagram now is probably the cooler social media. But everyone would post that their child had open heart surgery, and they survived and did great and recovering. But no one talks about poop problems with their friends, or posted on the internet that, oh, my child hasn't pooped for 6 days in a row now. That just doesn't get posted. There is no poll that asks that. And no likes or little heart emojis or anything. There is a poop emoji that's very popular, by the way, especially in our clinic. But, it's something that's important. And as I listen, I hope that we often see the patients with constipation later on, getting through all the airway and aerodigestive issues first. But pooping is a problem from the beginning typically too. We just overlook it. And so when there's time and opportunity, I think it's important to talk about it, because all patients and lots of people, you walk into Costco right now, one of the first things you see is a big forklift crate full of Miralax right when you walk in. There's a reason for that. So I do have a couple poll questions for the audience, and we'll get the answers in a while. They're not hard questions like, does your child suffer from constipation? Yes, no, or unsure. So please answer that question, and we'll get back to it in a few minutes. But I think when I'm going to talk about the multidisciplinary approach to taking care of constipation, it's really an amazing issue that we deal with. And Ajay alluded to it a little bit at the beginning, and we'll talk about it a little bit now, but people don't realize that your GI tract from mouth to anus and everything in between has a nervous system that's called the neuroenteric nervous system. It's a fancy name for a bunch of nerves. It actually has more nerves than your brain. And understanding that, no one could say they understand the brain. We certainly don't understand how the neuroenteric or nervous system of the GI tract works. So a lot of what I'm going to talk about is how to overcome the problems of the neuroenteric nervous system or the brains of the GI tract, but it's not curing the problem. It's just trying to overcome these problems. So I had to buy some time for that poll question, but we have another poll question coming up is, are you satisfied? We got the answers already for the first question. So half say yes, their child does suffer from constipation, half say no. And what interests me the most is actually that no one was unsure. And I'll talk about the workup for constipation a little bit, but I think there's a lot of people who are constipated out there who don't know it. And that's one of the things that we can talk about over the next 15 minutes or so. So the second question is, are you satisfied with your child's bowel management plan? Whatever that might be. It might be dietary, it might be taking some medications, it might be physical evacuation, whatever it might be. Are you satisfied with your child's management plan? And so we'll let you answer that question. We'll talk a little bit more about the options that are out there. And what I'm going to talk about is I'm going to go over a bunch of slides of what we have at our colorectal center is called Bowel Management Program. It's about a 7-ish day long program where we do some intensive investigations as well as treatment, trying to get the right bowel management for your child. And each child's different. Each child's behavioral issues are different, and each child's constipation issues are different. And trying to figure out the right management for your child's important. But on top of that, the other term, and I'll show some data in a few slides, is it's really what works for you and your child and the quality of life that you get or trying to improve upon during this time. And so what, for me, the perfect bowel management is you're going in the toilet every day, emptying your colon, but that might not be the perfect bowel management for your child or your family because it takes a lot of time and effort. And so what we try to do is figure out what is the best and what is the outcome you want for your child and your family. So here we have about 2/3 of the families are satisfied with their child's bowel management and about 1/3 are not. So those of you who are not, hopefully I get you some ideas. And those who are satisfied, maybe you could share with us what you're doing that's working. So we always can learn new tricks. So one thing that we did know, and when I started getting interested in quality of life, is I said, so how bad is the quality of life for patients with constipation and fecal incontinence? So we did a survey of about 170 caregivers of children, school-age children, and filled out a quality of life survey for the children and for the parents. What was a little interesting, and maybe it was just we didn't think of it at the time, is that the parents of children who are suffering from constipation and fecal incontinence are really stressed. This is a very stressful situation for these families, and they scored as high as patients who had cancer and inflammatory bowel disease as the stress level for these parents, just based on the issues they're having with constipation and fecal incontinence. So now I'm going to talk about a bowel management program that we have, and it is a devoted, dedicated, week-long process and lifelong, to be honest with you, program that we run. And I will go over what it is, what it takes during the week, and some outcomes that we have. So the bowel management program really is an individualized program for children who are having either constipation or fecal incontinence issues. It's a combination of diet, oral medications, behavioral modifications, physical therapy, which is a huge part for some of our patients. Some patients do enemas or like a mechanical evacuation of the colon to empty it and stay continent. And the goals are two. One, to evacuate the colon adequately so you're not dilating. You could get into this vicious cycle of being constipated, trying to treat it. Stool leaks around the constipation gets worse, and the colon keeps dilating, which then it doesn't function as well, and the muscles and the nerves in that area weaken, and it's just a vicious cycle of getting worse and worse. So trying to maintain some sort of maintenance bowel management program for the health of the child's colon and GI tract is quite important. That's some information. This is a slide of our multidisciplinary team. And so as the colorectal team, we are sort of the core, and we try to have many, many different services involved in our colorectal clinics. And we all see patients on Fridays here at Children's. And I'm missing it right now, but they're still going. And we involve urology and gynecology when appropriate, GI IBD when they have inflammatory bowel disease. GI motility is a huge part, as Dr. Cole knows and talked about, but he and 3 other of his partners, we are lined up in clinic 3 out of the 4 Fridays, and then a few random days in between. Dr. Cole and I have clinic together to take care of patients with GI motility problems, behavioral medicine, obviously, physical therapy for those children that are able to follow commands and train. It's just like if you injured your knee. If you injure your knee, you go to your physical therapy and you try to get better and strengthen the muscles around your knee. Well, we try to train and strengthen the muscles in the pelvic region if that's possible. Nutrition is a huge part of this and very important, as Dr. Cole mentioned. Radiology is a big part, and we do some studies. And we call this clinic our MDMC, or Multidisciplinary Motility Clinic. Like I said, we have it basically 2 out of the 4 Fridays a month at our center. It's a dirty job, and you have to want to get dirty to participate in this. It's not easy, and I like to say we do not have Cincinnati magic dust to cure this very easily. Everyone needs to roll up their sleeves and get involved and get to the point where we're hopefully making the quality of life better. And there's a balance, and we have to get to that balance and get there. But our bowel management week consists of usually a number of events, and I'll go through the days sort of quickly, but on usually the Thursday before the main week, there's evaluations and testing going on. We align that with other tests and maybe aerodigestive testing or MRIs or other tests that need to go on. We have an education or an orientation session that educates the families and patients on what to expect for the next week and afterwards. We have books there and manuals and logs that we take care of. And I'm very excited that within the next few weeks, we'll actually have an app that could do all this, which I've been 2 years in the making, and it's very hard to make an app if you want to make an app. But it should be great. And it's all about expectations. Like I said, we're trying to meet everyone's expectations and do what is best for the patient and the family. On Friday, you meet the team. We have a physical exam and evaluation, and we come up with a customized, individualized plan for that patient. Usually involves either enemas or laxatives. I'll go into that in a minute or two. And we try to figure out what will work best for you. So we have 2 main branches of our bowel management program. There's enemas or laxatives. Enemas obviously is something that's transrectal. You put a flush into the rectum and colon, stimulate the colon, and then evacuate the colon. It usually takes about 45 minutes to an hour to perform the whole procedure. It's obviously more invasive, but more aggressive, has better outcomes, really helps evacuate the colon, and has very good results. But it takes a lot of work, and you have to have the patient who's interested and able to cooperate with that, and the family. So it's tough. The other end is laxatives. That's just taking medications to help evacuate the bowel using laxatives. Laxatives is a big term that I want to go over, and I'll go over that in a minute. So our enemas usually is a combination of saline, salt water, and a provocative agent such as glycerin or phosphate that sort of stimulates the colon to evacuate. Laxatives comes, a lot of people use the terms laxatives loosely, and I use that, that's a joke. And so laxatives, you could have stool softeners, which is like Miralax or Colace. Those just bring water into the colon, loosen the stool, which can help evacuate. Then there are stimulant laxatives, and there really are only 2 stimulant laxatives available in the market in the United States. That is Senna or Senecot and Bisacodyl or Dulcolax. And those are the agents that actually make the colon squeeze and help push the stool out towards evacuation. And so we promote stimulant laxatives because I think just loosening a stool doesn't always fix the problem, especially if you're trying to get evacuation. And so sometimes you need both, but we need to make sure that the stool actually propels forward. And we know in the CHARGE population that the motility in these patients is not normal and the colon isn't working well. And so using these agents might help with evacuation. And Senna we like to use more than Dulcolax only because it comes in multiple forms. It comes in chocolate squares, pills, and a liquid, unlike Dulcolax where you really have to just use the pill form. Whether you do bowel management through us or elsewhere, I do caution you that just taking these medications might make things worse and not necessarily better. Because if you're starting off constipated, I tell families when I meet them, I'm just a simple plumber. And I'm just trying to get unclog the pipes a little bit. And if you have a clogged pipe and you just put something to sort of squeeze and try to get things out, but the pipe is already clogged, it's going to be very uncomfortable for the child. They're going to get really bad cramps. And you really have to make sure that the pipe is empty and then get on a maintenance program. And that's really the essence of bowel management, is emptying the pipe, making sure it's empty, and then getting on some maintenance program that keeps the pipe empty. And how you do that is obviously different for different patients. So during the weekend, you get to have fun and play in Cincinnati. And then during the week, there are parent sessions and education sessions and physical therapy and other activities. And then every day we're changing or tweaking the plan for your child's bowel management. So instead of going to the physician and saying, all right, let's increase the dose by 10 milligrams, come back and see me in 3 months, we're saying increase the dose by 10 milligrams, come back and see me tomorrow. And during that week, we're making multiple adjustments, trying to get, in a trial and error fashion, the right dosing. So bowel management troubleshooting, that's what we do during the week. I like this slide. I think it's cute. But if anyone has questions, please holler. And I guess we'll take some at the end. At the end of bowel management, we hope we celebrate and have a good ending. That's some of our GI colleagues having a little bit of a good time in clinic. You have to have fun in bowel management clinic, otherwise it's a rough week. Responsibilities after bowel management. So what I think is really important is, yes, it's a bowel management week, but it's a bowel management forever because things are going to change. Hormones change, diets change. And so we usually have follow-up at 2 weeks, 3 months, 6 months, and a year afterwards, and any time in between. And so we have a team of nurses and nurse practitioners that are constantly handling little issues and tweaks to try to make sure and individualize the patient's bowel management to get it on the right track. So what are our outcomes like? Because really that's the important thing. We could do all this, but if it's not making people better, then it's really a waste of time and not worth the effort by the families and the commitment. So we followed 222 consecutive patients through our center and looked and used a validated quality of life study as well as a severity score study to see what their outcomes are. And so our quality of life went from like 70% up to on average about just over 90% following this. And this was sustainable. What was really important is it was sustainable for over a year. It wasn't just, oh, after the week you were better, but when you went home, it didn't work. It worked and actually improved over the course of a year. And then what were the outcomes? Well, we looked at how many times were they having accidents or not moving their bowels over the course of a week. And at the beginning, it was 3 to 4 times per week on average, not having accidents. And a year, it was less than 1 time a week. And so again, some patients were just trying to treat constipation. Some patients were trying to treat fecal incontinence. But you have to have a program that's only successful if it's sustainable. And so I think this is about, we figured under testing this, it was statistically significant, and about 81 to 83% of our patients were successful. So what happens? Do I have a few minutes still, or are we running out?
Yeah.
Running out? Okay, a couple of options of what happens if things aren't going right, or if you are concerned. of doing transanal or transrectal enemas, there are things called appendicostomies or MACEs or ACEs. That's when we take the appendix from the colon, bring it up to the belly button as a little hole, like the size of the end of your pencil. And we could put a tube in there and flush the colons out that way. So that's an option when you don't want to do transrectal irrigations or enemas. That's what it looks like. There's something called Peristine, which is an enema device that's sold out there. It's quite expensive. Insurance companies eventually cover it, but it's an enema device that some families use. There's something called a sacral nerve stimulator that we could, again, neuromodulation, like we talked about the vagus nerve being important. We also think the sacral nerves on the other end are important, and this helps stimulate the sacral nerves. And I think sort of tying into what Dr. Call said is it takes an army, it takes a multidisciplinary group. Dr. Call's in these pictures. You could see him in the back there hiding, but he's a big part of it. And it's really working together because not one team can fix everything. It's a group of us that could help, and more brains the better. So on that end, if you have any questions, I hope to answer it at the end. But
Thanks, Jason.
You're welcome.
Yeah, you guys definitely. We've got a few questions that we'll make sure we try to get to at the end. But yeah, send them in, live chat them in, whichever. Lucy's monitoring those for us. So Amy, I'm really curious to hear your perspectives on this. We think about this stuff a lot from the clinical end, and sometimes that's not exactly where the families are coming from. So yeah, thanks very much for joining us.
No, I'm honored to be here, and thank you for asking me.
Yeah, I'll bring your slides up.
Okay. I have a 15-year-old son named Ben with CHARGE syndrome, and my mom fail of the day was I didn't include a picture of him in my presentation, so I'll take that as a loss today. But the biggest struggles we have had over our lifetime with him has been GI related. He is nonverbal with a trach in a feeding tube, and he also has cerebral palsy. So I was expecting the trach, the breathing issues, all of those different things. I had no idea that the bulk of our stress, his pain, would be related to feeding issues, both tube feed and also with having bowel movements. So I was going to kind of just give a little rundown of our history and what we've experienced. Obviously, what works for us isn't going to work for everybody, but over the years, we have tried, I feel like, everything. When he was little, we first started noticing he was having trouble tolerating feeds, which when we were presented about getting a feeding tube, I understood, okay, he can't swallow. This is a solution. I didn't understand or wasn't educated enough to know that that meant he's going to have a whole slew of issues relating to just tolerating that. I thought, oh, easy, food goes in the stomach, he tolerates it, we don't have to worry about the swallowing. I had no understanding that it wasn't that easy. So he was getting formula that was made for him depending on his weight and calories, and he wasn't tolerating it. So we kept on adjusting the calories. We kept on adjusting the food. He would retch. He's had a Nissen. So we thought, okay, is this because his stomach is small and he couldn't throw up? But he was very uncomfortable at a young age, and we just really weren't understanding why or knowing how to help. And we were working with, we are lucky to be in Cincinnati and have a great team of doctors. So we were working, trying different things, tweaking everything, switching to a point where we even went to try a GJ tube where he was on continuous feeds, and he doesn't walk, he's non-ambulatory. So that added a whole nother element of carrying a pump around with the child. But at that point, if you've been there, you realize if this can make them feel better, I'll do it. And we finally got to a point where we found a good mix, and it didn't really make sense why it worked. And that's the other thing I would take away is like a lot of the things, he's on a very hypoallergenic food called Elecare Jr. He has never shown any reason why he needs to be on that. He has no sensitivities, he has no but it works. The calories work, it works. We do small bolus feeds through the day of only 120 mLs, which is not much. And he gets 3 of those, and then he's on a pump for 10 hours at night. We have been doing that for years because it works. As a lot of you know, it's like you don't want to rock the boat. And so we felt like we were at a decent place, but it wasn't a great place. And then we threw in the issues with having bowel movements. His stools were always liquid. He went daily, but he seemed to have so much trouble going. He would retch if it was too close to a feed. He would cramp. We were starting to see a lot of really aggressive behaviors, self-injuring behaviors, and just acting out. And he was turning into a child that I didn't feel like it was him, because we were wondering how much is this is charge, behavior, acting out. But they always seemed to precede something, whether it was a bowel movement or passing of gas, and they flipped on really fast and they went off as quick as they went on. And we were at a point when I think we started seeing Dr. Call where it was 10 major outbursts a day of aggression, head banging. He was hitting himself. He was scratching, biting. I mean, it was at a point where the quality of life was not good for anybody in that house. I thought, we're not going to keep a nurse. We're not going to keep our own sanity. He's not comfortable. And at that point, I started reaching out to the CHARGE community and searching among, which if you don't know if you could search among the CHARGE Facebook page, I highly recommend to try that, because you could search keywords and bring up any posts of people that have talked about that issue. And I stumbled across another CHARGE mom who was dealing with similar issues, and we connected, and we had a lot of the same stories. Hers was leaning more towards abdominal migraines, and I started journaling his pain and everything around, and mine wasn't really fitting that way. But it brought me to actually Dr. Blake, who was doing some research on vagal nerve dysfunction. And when I read her research and what she said, it just made sense. It clicked, and I felt like this, I mean, we can manage the bowels because we were giving him suppositories every other day. We were giving him Senna. We tried every laxative. I mean, we tried it all. We did abdominal films. We'd done every test we could possibly do. And there was really no concrete evidence on why he was having the trouble he was having. So we talked to Dr. Call and we said, can we start trying a nerve pain medicine? And once we tried that, it changed his life. It changed my life. His pain has now gone to one episode of a couple minutes of pain once a week, from 5 to 10 a day, every day that lasted from 5 to 30 minutes. And I would say my biggest takeaway is that don't underestimate that the behavior is pain related, because he's nonverbal. He couldn't tell us, he couldn't locate. It seemed to anybody from the outside, this is just a kid that's acting up, that has behavior problems, that isn't in control. And that wasn't who he is, and that wasn't who he was. So once we were able to get that pain under control, he's been a happier boy. And I realize that we're probably going to have to tweak as we go, because doses is going to change. The medicine may not stop working, but definitely advocate for your child. You are with them every day. The doctors, they have the best intentions. They see your child for 30 minutes every 6 months. They don't live and breathe it. So you kind of know if your child is doing this for something, if they're wanting something, if it's a behavior, or if it's more than that. If you think it's more than that, I definitely would say to push to say this isn't right. So
I got a question for you. So
Yes.
It's a really common thing in that the behaviors and frustrations and aggressiveness that comes out, and the question of whether it's something pain related, and particularly abdominal pain related stuff. You talked about journaling being one of those things that helped you out and differentiate between migraines and other potential causes. But I'd love to drill down on that and figure out, how do you tell other parents how to observe their kid, and what are the cues that helped you figure out that you thought that this was going to be abdominal pain related?
I would say for us, the biggest thing that when I was journaling, it was after feed, after suppository. Sometimes it could be within a 1 to 2 hour window, but when he wasn't getting the suppository on that day, he wasn't having it. Or we would smell gas. He would pass gas afterwards, and then it would improve. We've also found, just with the vagal nerve and things changing, lifestyle changes, school starting, school stopping, and kind of understanding that any change in his life, in his body, could affect that nerve and cause his pain to be worse, to me was eye-opening, because before it's like, why is it worse now? Why is it you know, he's out of school for the summer. Why is it bad? Nothing's bad. But then even if he'd have surgery, after surgery, every time getting his body back on track was terrible. If he had an illness, a cold, just taking some medicine, he would be out of sync again. Every single thing seemed to throw him. And that's the one thing I kind of noticed from the journaling was that anything threw him, any change threw him, and then the cause was usually something that I could pinpoint to a bowel movement or feeding of some sort.
That's really helpful, and I bet you there's a ton of people who are just like nodding their heads vigorously as you're talking here. Kim, do you want to, anything you want to comment on this now, or do you want to just go ahead with your talk? Did you have any slides, Amy? They finally got your slides pulled up. Let me give you a chance to do that.
I kind of just did it through the years of all the different things we've tried and the tests we've had. Oh, and I didn't mention he is on a medicine for reflux. That's something that we just, in case he is refluxing, we're always keeping it at bay. And then I talked a little about the bowel movements. And we did have some of the issues where they would find in an x-ray some form stool with a lot of leak around, which is why we were seeing him on a daily basis. But then we also had times where everything was clean as a whistle, and they're like, nope, he's good. And then, just reaching out to other families and the nerve pain medicine, and that, your kid's next. And the one thing, too, that I think was talked about a lot is it's not a perfect fix. And I never expect it to be a perfect fix, but if it can be even remotely better than we were, that's a win in my book. Yeah. And and don't try too many things at once. That's another thing is when you're in this world of, it feels like everything is going to explode because their pain is so bad. You're really quick to, let's change their food. Let's give them a suppository. And then you have no idea what helped. And then oftentimes you find that it's all worse when you're done because you go back to what it was and you really didn't know what fixed it. So that was all I had.
Well, thanks so much. If you guys have comments for Amy or questions, please send them in, and then we'll try to get to them after a little bit. Kim, you're up next. Did you want to address that or just go into your talk? Would that be, what's the better flow for you?
I'm going to share my screen, and I'm going to see if I can actually get my presentation up, which is the first matter of course. Do you see my presentation, Dan?
Not yet.
Okay, so I shared screen, maybe share there. Oh, what about that?
There you go. We can see some of what you're, yes.
Can you see all of it, or let me put it on PowerPoint mode? So what about that?
Yeah, you just got to get your control panel for the display screen off.
Okay, how do I do that? Yes, we've been practicing, yes. So I've got the full screen up here. I might need Jay's help, who's going to be around.
There you go. Now we got your full screen.
I think somebody's helped me at that end, actually.
Excellent.
Okay, well, thank you. Thank you what a very interesting presentation already. I've learned a lot. I like little brain, but I think I might call the enteric system the big brain, actually, of everything. Amy, that was, I'm glad you've got things more sorted out with Ben, and I'm glad we could help at this end in Canada. So we're a small centre compared to you guys. My goodness, what I would give to have all of you guys working with me is sort of me and a couple of others. So it's we're in Canada, Nova Scotia. I work at Dalhousie. I've been there. Oh dear, I did have it off actually. Sorry, I've been there. It was off earlier on. I popped it on for something else. Okay. I've been here for 23 years. I got involved in CHARGE syndrome back at Great Ormond Street in England, and I've got to tell you, it was one of the first papers I wrote. Feeding issues, GI issues were there, and it was bugging me right that 35 years ago that nobody was interested in. Nobody was interested in the constipation. Nobody was interested in the upper GI, and they all had Nissen's fundoplications over and over again. And I was always interested. So this is 35 years ongoing interest. These are two of my lovely little girls that I've looked after since they were babies. That's Kennedy and Mackenzie, and they're sharing lunch together. They're having a tube feeding lunch share, and they're now in their 20s and doing extremely well, which I'm pleased to say. And I'm going to show you some of my work, mainly. As we've just heard, there hasn't been a lot of work on CHARGE syndrome GI issues. I have a couple of papers on my website that covers a lot of what I've done, which is, I think, worth reading. It's always worth doing small clinical studies. So I have some case reports. One is 2017 late dumping syndrome in a 17-year-old with CHARGE syndrome. And I would certainly direct you to the website because it's got other things on it as well. It's got the checklist, as Dan was talking about. The GI part of the checklist is right up here. So it's a good chunk of checklist. There is feeding studies and things on there. It's a checklist that I'm proud of. I know Cincinnati likes it as well, but they were the first people to pick it up and use it. And all my students, you can see them here on the right-hand side, use it. They learn about CHARGE syndrome. The parents take it with them. And I think it's an amazing thing to use to direct your professionals to the bits that get missed. So a call out for the checklist. And I also have a feeding scale for CHARGE syndrome, which again has not been formally published. It's been researched. Can be found again on the website. It's also going to be in the CHARGE syndrome book that's coming out soon. And what I like about the feeding scale is very much has the questions that I bet you guys would like to make sure they get addressed. So things like moving the food around the mouth. We heard about the tongue, which we think is cranial nerve affected as well. Things like pocketing in the cheeks and palate. And I had one of my students do a whole research paper on cheek pocketing. So that's an easy to score. This is great for your OT, for yourself, for changing, like Amy was saying, when you change things, what a great doctor, Amy. Just change one thing. Don't change lots of things. Keep a diary. This is a great thing to keep and actually keep track of your feeding score. So out of 100, higher score, the worse in the feeding. So 3 uses for the checklist. I've really just said it: to track the feeding, to warn the physician, and to see any difficulties. And that's one of my nice students with one of my other little patients. So I'm now going to talk about the zebrafish. We've heard about the enteric nerves and how important they are. I always tell my parents, you've got a brain up here, but you've got a much bigger brain down here. So we'll call it the big brain now. And that's run by essentially the vagus nerve. So you can imagine, Amy's given a lovely description again of if you're pulling on a nerve or that nerve's not functioning properly, or it's just, think about any sort of nerve condition, it can be painful. And certainly it is with CHARGE GI tract. So we studied zebrafish because they're see-through, cheap. You can breed them. Our first pair came from Texas, and then we bred little CHARGE zebrafish after that. And we've done some experiments with them. And I want to just highlight, again, this paper's available. I want to highlight a couple of the key things. These little CHARGE zebrafish had smaller GI tracts, smaller stomachs. The inside and the muscular and the look of the GI tract was normal, but the nerves weren't. They had decreased and disorganized vagal nerve projections. And I think this is the only paper that's actually that actually has the results to prove this. I'm sure there'll be other experiments coming up, maybe in other animal models. But this is a big one because we know that the zebrafish makeup is very similar to our makeup genetically. That's why we can study them. You wouldn't believe it, but we are like zebrafish. Less ability to empty their GI tract, only minimally improved by the prokinetics. That's the pusher outers. So we've heard about constipation being such a problem. I'm so pleased that you've got a wonderful team working on that, because that's a problem in my general clinic as well. This is a couple of slides showing what I've just actually told you. This is normal on this side, regular zebrafish. This is a CHARGE zebrafish on this side. You can see G is gut here, G is gut there. And what you can see here, look at all these nerves, these enteric nerves, these red projections, much fewer down here. So that doesn't take rocket science to see that the little charged zebrafish are much more affected. Well, they've got abnormalities there that are obvious. We did something else, which I think was very, very interesting with our zebrafish. We fed them a meal, which was fluorescently tagged, so you can see it going through the gut. There's 6 hours, whoop, it's all gone out. It's all gone out the other end. With the charged zebrafish, actually what you see is very interesting. It actually doesn't get into that bolus. It's not doing that sort of, the gut's not doing the squeezing and bolusing it up. A bit like your bread machine, it's not doing that. And it's not able to sort of go through, it's sort of like, it's just not happening. And then it's not even in a bolus there. And look, it gets into a bolus, but it's far too late. So you can imagine that that's probably causing all your constipation, a lot of your problems. And then if you've got a big bolus there, that may be causing pain as well. So I'd like to say that I've spoken to lots of parents about this, and Amy, you may have been in one of these studies as well, but we haven't actually published this. But I think going through my results, I'm going to put this on my website as well. It's what parents felt worked. This is only one slide from the data that we've got. This is what they think doesn't work, and this is what parents think work. I can't remember our N number, it's about 50, something like that. But I really want to point out that something like abdominal massages, something that might be so simple, and warm baths, like you're actually physically massaging the colon to help move things along. And that's, I think, where your OT and some people can come in, and probably like Amy's son, Ben, because he's got more problems with his cerebral palsy and things like that, it probably is an additive to not exercising, standing up, moving around. I don't know him at all, but I would expect that part of it is that he's sedentary. Exercise is very important as well. And this pocketing of food can be a very difficult thing to overcome. I think one of the things I've heard from parents is using a stimulation like Vitacin. We've heard a little bit about diet and how important that is for the constipation side, and we do get some of our kids, it's a difficult diet to keep to, but a FODMAP diet, so low in all the things that are called not simple carbohydrates, bread, pasta, things that everybody loves, pizza, but if you can reduce that and small amounts of food regularly seems to work well. Exercise and weight control. So some sort of dietary help can be helpful. And this can be, I think, again, with Ben, he was on a very, very, not even a FODMAP, he was on a very, 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 I think Amy said, a hypoallergenic diet. Mm-hmm. So the microbiome is our new research that we're doing. This has been very, very popular in the press at the moment with kiddies with autism, kids with more of Crohn's disease, more inflammatory bowel disease. So what your microbiome here is, it's a whole, you've got your nerve center, which we're talking about, the vagus nerve, and then you've got the insides of your gut, which is controlled by all of these sort of these things. So are you genetically predisposed to a certain microbiome, certain diseases, let's say CHARGE syndrome, certain drugs and diet. So with the microbiome, we call it, it's really all those bacteria that's in the gut, and it's called a gut microbiome. It's like a whole cosmos in itself. Typical microbiome has lots and lots and lots of different types of bacteria. When that goes wrong, we call it dysbiosis. So gut dysbiosis is associated with lots of disorders, as I just mentioned. And our research question was, you might want to poll this. I haven't done any polls on this, but does the gut microbiome differ in individuals with CHARGE syndrome compared to others? What do you guys think? So that would be one of the questions. And then another question could be, and I don't want you to answer both, because I doubt whether you can answer both, but if so, does the change in the gut microbiome correlate with the GI symptom? So I want to show you that result. We haven't actually looked at the data for dietary factors yet. This is our provisional data. We actually have more data. I wasn't able to get it on the slide for you, but there will be more data. And once it's on the slide, which I think, or once it's available, I'll try and put that up on my website in the next couple of weeks. My student's going to be presenting it actually to our faculty. So I want to present just one little bit of information on the microbiome. Again, it's not published yet, but we looked at sibling pairs. So it will be your little person with CHARGE syndrome and their nearest sibling. And if there's no sibling, we would do a parent. So what we found when we compared sibling pairs with different GI scores, we used the GI scores to see how many GI symptoms. So if you had somebody like Ben, he would have lots of GI symptoms. His score would be very, 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 very high. Whereas somebody who doesn't have GI symptoms, maybe Ben's brother or sister or mum or dad, would have lower. So when we looked at the person with CHARGE, they had you can see the difference in just the difference in the two. There's your control, there's your sibling or parent control, there's your person with CHARGE syndrome there. They've got lots more of this called Bacteroides, much, much less of the Firmicutes. That's another graph just to show it. Then you look at a pair of siblings. So we have many kids, as you saw from the slides that we polled in the presentation, who don't have GI problems, so don't have constipation, and you can see how equal they are. So this was good results. We actually are, even with a low number, we showed significance. So the Bacteroides have gone down and this one has gone up. So what does that mean? So the CHARGE microbiome is different, and we've actually got even more results to support that. The trend, so the Bacteroides are important for lots of things, healthy gut, immune system. I do wonder whether if you've got too much of that, it's actually the balance. It's the balance that's important. It's actually what we call decreased diversity. So what we're seeing in the CHARGE patients is very much like what we're seeing in the IBS, IBD, is that there's decreased diversity. We see that in obesity and autism as well. We've got the papers to support that. And the Firmicutes, which is very interesting, ferments the carbohydrates, and that's a decrease is seen in IBD as well, and we're seeing that in CHARGE. So the next step we want to do is to increase our study population. And I'm going to put this one up. That's the emails where you can reach us all. That's my 2 new students doing this study with myself. And we're actually going towards the adult side, looking at behavioral scores as well. So we're actually doing gut and behavior, which I think is going to be very interesting. That's this year. We're looking for younger and older people still with CHARGE syndrome. And then to answer some of your questions, well, what can be done? There is some novel treatments out there that we may see coming through, so it's worth looking out for them. Stool transplants, fecal transplants, but there's actually milks that are being looked at that actually have some of that makeup that are actually should be beneficial. So look out for that. There's always risks with things, but I think this is going to be very interesting new research. And keep an eye out for our results, and it's been great chatting to you. Some of the kiddies, some of my students, we all look like we're having fun, but there's not many of us. Thank you.
Well, thanks, Kim. Great stuff, and yeah, it's great to see some of the zebrafish data are really intriguing, like the fluorescently labeled gut transit studies. Do you really wonder if that is a very relevant model to what we see in some of our kids with CHARGE?
Yeah.
I was going to throw out to the panel a bit, and I wanted to make sure Amy gets a chance to chime in. One of the questions that came in online was, we've touched a little bit on diet and how important that is. Do you guys have any approaches to how you recommend starting out diet? If you have a patient who has trouble feeding, tolerance, constipation, those kind of things, bloating, is there any approach that you guys start off with that's kind of systematic?
So it's primarily a nutrition issue, and of the kids that I've seen and read about in CHARGE, there's a lot of literature on that, but I don't think there is a malabsorption issue. The absorption of the gut seems to be normal. At least we don't have evidence that there's malabsorption or any publications about that. So it's not a problem with malabsorption. So technically, you could give them even a broken down formula, non-elemental formula, and they should be able to handle it. But that's not the only part of the story. The other part is the sensory stuff that these full proteins that can stimulate the vagal nerve. Now you have to remember, I mean, I could spend a whole day just talking about how the vagus is so important to the gut. The vagal nerve, which is the 10th cranial nerve, is both a sensory and motor nerve. So it takes the sensations from the gut to the brain. The brain interprets those signals, and then he sends the motor effect to the gut. So there's the motor issue and then the absorption issue. So there's no absorption, but there could be a problem with those full proteins that are going through the gut that are somehow stimulating the sensory signals that the vagal nerve is picking up and sending to the brain and causing the discomfort. The example for Ben, he's a great example of that. He did much better on a elemental formula, on Elecare Junior, which is a broken down formula, and it was a mess with all the complex, the full protein formulas that he'd been on before. And Amy, correct me if I'm wrong. And he did much better, but he didn't have any evidence of any malabsorption. Mm-hmm. So it's really, like Amy said, there's not a lot that we understand, but with the knowledge that we have so far, that's the only way I can explain it, that it's really not an absorption issue that the gut can't absorb. It's how the gut is sensing these foods that are in the gut and interpreting those signals coming from the gut as painful or pleasurable, etc. The other issue is the microbiome, which Dr. Blake touched upon. We don't really know a whole lot. There's a lot of the jury is still out there. If there's really a huge role of the microbiome in our behaviors, but it's becoming more and more clear. There are some experiments that they've done in children with autism, for example, where they have definitely shown changes in the microbiome affecting the child's behaviors. So we are still not there to conclusively say that yes, the microbiome for sure, really changes the behaviors or not. But there's more evidence coming every day that there is an impact of the microbiome on behaviors. Then the other thing is the more elegant experiments have been done recently, where they've shown that the microbiome actually helps to develop the enteric nervous system. So the right kind of microbiome actually causes the enteric nervous system, the second brain, or the little brain that we talk about, the big brain in the gut, it actually causes its maturation. So is there a problem? And that's been my biggest question in children with CHARGE syndrome. Is there a problem with the maturation of the enteric nervous system? There is some data to suggest that the enteric nervous system, their migration, it's a migration problem, primarily coming from the work that Dr. Blake has done, where they didn't see the enteric nervous system developing normally all through the human gut. But there's really, the zebrafish gut. And Dr. Blake, correct me if I'm wrong, there haven't been any human experiments or any human studies done, which is actually can be easily done to get some human tissues to study the enteric nervous system on those. So there's a lot that can be done there to answer those questions. So a lot of question marks, but we have the ability, we have the potential to answer a lot of those questions.
Amy, one of the things you mentioned was a little bit of trial and error on the formulas and diets that you're feeding them. I think the histories that we hear from a lot of our patients is that they have to go through that to try and figure it out. Breaking that down a little bit, how long did you have to try with one diet before you say, all right, that one doesn't work, move on to the next, that kind of thing?
I'd probably give everything a good 3 months. That's kind of my...
Wow.
Because I took it so slow to make any kind of switch. If there was any switch from a formula he was on to a new one, it was like quarter strength, new stuff, 3/4 strength, old stuff for a
Uh.
week. And then the next week, if he did well, and then it's like watching him like a hawk. Is anything changed? Is anything off? So I would make then half strength, then 3/4 strength, then full strength, and then give that a month. And then even watching water intake. And I've even gotten so much as the water temperature has to be lukewarm water temperature. Never
Wow.
cold feet, never too hot. I mean, and some of this may not even help, but it's one of those like you do this and you do that and it works and you go with it. So
But that actually brings back the point of the sensory function of the gut, which is, again, vagus is the nerve that is sensing what's going on in the gut. So, the temperature, the mechanoreceptors, the temperature receptors, etc. They're all, I feel, all of those seem to be affected in children with CHARGE syndrome. And Ben is just an excellent example of what I'm trying to say. And Dr. Blake, I'd love to hear your thoughts on that.
Yes, can you hear me okay?
Absolutely.
Yep.
Okay, wonderful. Yes, I agree with everything that you have said. What I would like to see moving forward, I think we need some actual more clinical studies with actual patients. I think that would be a really good next step to go. I think you guys have got amazing setup there, and I think you've certainly done some quality of life studies, but I think it would be, especially if you're going to bring kids in to get a full workup. Is there any way, I know we'll have to go through ethics, there's lots of things to do, but is there any way to look at more extensive workup that's going to help us answer those clinical questions? Because it's great to have the animal models. I really am very interested in what you said about the enteric nervous system developing because of the microbiome. And think about a lot of the kids with CHARGE syndrome, they're fed by tube, it's a real problem right at the beginning. Is that really affecting the microbiome right there and then? I'm looking forward to doing the behavioral work. We've actually just, we got ethics approval about 6 months ago, but we're heading, if anybody's interested in that, we're looking at standardized behavioral questionnaires with gut. I mean, even in some ways, Amy, you've done a little project with Ben. You know that his behavior is better when his gut is sorted out. I mean, it's not rocket science, but I think that there is certainly the gut. We all say we get that gut feeling. It's the gut is the feeling, as you've just said, the feeling part of the body. We think it's the brain, but it's certainly the gut. And that feedback mechanism is interesting. So I think trying to, and then the question always is to parents is, well, what's the answer? What's the treatment? So going slowly, working on things, diarying. I do all of that with my patients as well. I think the knowledge about this stuff helps other people, and they sort of can't just push it off and say, oh, it's just them. It's just a charge-like behavior. Tim Hartstone always said, behavior is coming from something. It's coming from pain. It's coming from, and it's communication. So I think there's, you've got a super setup there, and I'd be happy to be part of it. But if we can look at moving more research forward, I think it would be great.
All right, we got you on videotape saying you're going to collaborate with us. So we'll resurrect this at different times. With regards to the microbiome in these kids, I can't help but feel like it's perturbed by all the stuff we do to the kids over time. If you look at from infancy, on average, by the time the kids are 20 months of age, they've probably had 11 to 12 surgical procedures. And so much of what we do in the operating room, we dose them with prophylactic antibiotics. Add on top simple stuff like otitis media that requires a round of oral antibiotics. And I know we've messed up their microbiomes or perturbed them at least in some fashion. And I can't help but then throw in tube feeds, atypical diets, and then it's just a mess and difficult to really control for all those variables when we're trying to do rigorous studies. But it's something we should try to tackle. I wanted to try and get just one or two more questions that came in while we were online. It probably gets to that myenteric and vagal mediated reflexes again, Ajay, but somebody was asking, my kid's been fed by tube feed forever and seems to have problems with detecting satiety and fullness. And so they were wondering, does that perturb your ability to sense when you're full and those kind of things?
So that's a great question. Yes. again, the sensation of satiety is in normal human beings is through hormonal effects as well as through the vagus nerve. So they both, the hormones and the nerves, give you that sense of satiety. So if that's affected, which again goes back to my thing of the sensory component of the vagus nerve, it's not working well, or there's hormonal abnormalities that sense the satiety are not right, then you don't feel that satiety. And that's one of the reasons why they would, either keep eating or they don't express their hunger when they're hungry. So yes, it certainly can. But one of the lights at the end of the tunnel I've seen in most of our kids with CHARGE syndrome, as they grow older, their feeding issues get better. And I never could understand, is it just because we are trying different things and they eventually find the right, combination of feeds, medications, etc., and that's why they're doing better? Or is there something that gets better with time? The enteric nervous system develops and matures over time. And if there is truly a deficiency in the enteric nerves, the migratory deficiencies that Dr. Blake has talked about, are they compensatory changes in the body that occur over time that overcome those deficiencies? Is there a role of stem cells there? So if we put those stem cells there, they get better with time. So that's like a whole, brings up a whole, opens up a whole Pandora's box.
Jason, I got one for you that came in. Somebody was saying, I fed my child with the same diet very consistently, and some days the gut function and bowel movement seem pretty regular, and then other times we go from the spectrum of constipation to just diarrhea. And asking, is that indicative of an irritable bowel disease?
It's a great question. And I was just thinking of all the things I learned and gathered listening for the last hour. I think what Amy said is hit home to me the most. It was two things. One, you said, and I think it surprised Dan a little bit, in that when you made changes, you went very gradual and over time. You were expecting her to say a week or 2 weeks, and she said 3 months. And I think that's one of the things. The body does not like change. And I think in CHARGE syndrome, that's even exaggerated, exactly. And so I think and so you said that a slow time to change and only one change at a time. And so, this family who's asking the question has already sort of standardized the diet, yet they're still not getting the consistency of the bowel. And why is that happening? It's because we don't understand the bowel and how it's working. We know that when you feed, and I don't know what feeding schedule this patient's on, when you dilate the stomach, there's something called the gastrocolic reflux. And when they build huge skyscrapers in New York and Chicago, they know between the hours about 8 and 10 a.m., the bathrooms have the greatest use. And they build bathrooms and pipes and drainage systems based on this fact that everyone eats breakfast, or most people eat breakfast. I eat too much of it, but most do. And you stretch and contract. And the way this GI tract works is such an enigma to us. Dr. Cole and I meet all the time, and we get into these philosophical debates, and we use the term idiopathic constipation, and you may or may not have heard it. Idiopathic just means it's a fancy name for us to tell families we have no clue what's going on. And the other term that comes from idio is idiot, and we really just don't know. And I'm not calling you that. I'm just saying we as a field don't understand what's going on, because this family sounds like they're really trying to control the diet and do things. I was thinking, the things you could do that are a little easier, and I notice, is making sure that you're not feeding constipating foods, and staying away from the white foods or the white breads, and like my family. I have a daughter who's significant constipation. Probably shouldn't have said that. This is being taped. She's 15, and we have only whole wheat pastas in our house, and little things and water. You can't say enough about hydration in our patients, and so making sure they're hydrated. But I don't have a great answer for this family. It's just a struggle.
Well, I dealt with the same thing with Ben. He eats the same formula for 10 plus years, the same medicine for 10 plus years. Nothing changes. He gets every feed. His stool consistency changes weekly. the odor changes, which I don't understand that, because how come sometimes it's terrible and other times it has no smell? I just figure it's been up there longer. And but yeah, I mean, that's a lot of information, but we deal with the same, and I don't understand it, but it happens, and we just kind of go with it. So we have a whole system of how we describe what it looked like that day. Like, when his nurses say, soft serve, was it liquid? What do we, you know?
Mashed potatoes.
Yes. Yeah, we have
I don't eat mashed potatoes anymore. I say mashed potatoes every Friday about 20 times. It's terrible.
Well, you totally failed your 15-year-old daughter. But
Yeah.
I can't believe you did that.
Neither can I. I'm in so much trouble.
All right. Well, we are right at the top of the hour at 5 o'clock. I just wanted to thank everybody for participating in this panel. It was fantastic. Some of the comments we got online were lots of appreciation that there was a ton of information, and I think it resonated with a lot of the families that are living through this. So I think that's one of the great values of this. Kim, thanks for chiming in remotely. We'll get
My
those
pleasure.
collaborations going. Amy, thanks so much for your perspective. It was spot on, I gotta tell you, and very informative.
Thank you.
So thank you guys all very much. I wanted to just wrap up for this CHARGE Symposium. Despite being in a virtual format and some very different for everybody involved, I wanted to thank you. You guys were engaged. Know that just overall there were about 160, 170 people registered for this, and as the conference went on, more people signed in online. And at most points of the time, we had somewhere around 80% of those people actively engaged, and we could see it on the chats and the feedback and the questions submitted. So I love the fact that it was still somewhat able to be interactive, which is one of the key components and traits that we like in these small symposiums. I know the CHARGE Foundation is looking at their upcoming next summer meeting to be virtual as well, and we'll try to make sure that we engage everybody on that as well too. So thanks again for being part of this, and keep your questions coming via email on the website. Kim's website is great if you haven't tapped into that one as well. There's tons of information there. Any questions that you submit afterwards, we'll still try to get to afterwards. So if we didn't answer anything right away, give us a little time. And thank you guys again very much for plugging in. See you, Kim.
Thank you. Bye-bye. Wish I could be there.